Hello, today we shall be discussing about hypocalcemia, its various causes, and the most important topics will be pseudo-hypoparathyroidism, pseudo-pseudohypoparathyroidism, vitamin E deficiency, vitamin D resistance, and other causes. So causes of hypocalcemia are as follows. You have parathyroid related disorders, you have vitamin D related disorders, and other causes. And parathyroid related disorders, it could be due to the absence of the parathyroid glands, it could be due to impaired secretion of PTH, or it could be due to target organ resistance. So the absence of parathyroid glands, the most important cause is parathyroid surgery itself, or it could cause even from post-radioactive iodine thyroid ablation. The congenital causes for this absence are Deja Syndrome, autosomally or X-linked inherited hypoparathyroidism, autoimmune polyglandular syndromes, and infiltrative causes like hemochromatosis, Wilson's, amyloidosis, sarcoidosis can also present as that, and METs too. Impaired secretion occurs in hypomagnesemia, respiratory alkalosis, and mutations of the CASR. And target organ resistance occurs in Pseudo-Hyperparathyroidism type 1 and type 2, and also in hypomagnesemia as well. When coming to vitamin D related, it could be due to vitamin D deficiency, either from dietary absence or malabsorption, which is the most common cause, or it could be due to accelerated loss through impaired enterohepatic circulation due to the various GI causes, or due to anticonvulsant medications, or it could be due to impaired 25-hydroxylation due to liver disease or isoniazid. It could be due to renal failure where there is impaired 1-alpha hydroxylation. It could be due to vitamin D dependent rickets type 1 or target organ resistance to vitamin D, including vitamin D dependent rickets type 2 and phenytoin, or it could be due to various cancers. Other causes are, one is due to excessive deposition of calcium, which include osteoblastic malignancies and Hungry bone syndrome, or when there is impaired bone resorption either due to vitamin deficiency or bisphosphonates or rank L. It could be due to chelation from all of these like phosphonate phosphates, infusion of citrated blood products, infusion of EDTA containing contrast reagents, fluoride. Neonatal hypocalcemia could be due to prematurity, asphyxia, diabetes in mother, hyperparathyroidism in mother, vitamin E deficiency in mother, and infantile malignant osteopetrosis. And in HIV, it could be due to drug therapy or D deficiency or hypomagnesemia, and it could also happen in critical illness in pancreatitis or toxic shock syndrome. So destruction of the parathyroid glands, the most common cause is by surgery. There could be spontaneous infarction of the parathyroid tissue, or it could be a rare complication of radioiodine ablation of the thyroid gland for Graves' disease. Infiltrative diseases such as hemochromatosis, also in thalassemia happens. Copper could be deposited in Wilson's disease, and there could be METs to parathyroids. Coming to Deja syndrome, there is absence of parathyroid glands as well as the thymus. It occurs sporadically. There is embryological defect in the formation of 3rd, 4th, and 5th branchial pouches. But it could also occur in an autosomal dominant form. So the contribution of homeobox genes to parathyroid development is considered important here, and it is often also associated with other congenital abnormalities called the catch-22, and where there is an imbalanced translocation, or when there is deletion in the 22q11. So what are the mutations and deletions of chromosomes in DJODs? Microdeletion of 22q1121 to q1123, and a translocation and a balanced translocation could result in this. Point mutations in the gene TBX1 which is found to be in the DGOJ1 are found, and some velocardiofacial syndromes have no abnormality at the 22q11, and terminal deletions of 10p are also responsible. So when there is a terminal deletion of 10p, there could be two types. It could be in the DGOJ critical region, that is the 10p, or it could be in a more telomeric region, that is 10p14 and above. And when the telomeric region 10p14 is altered, there could be a mutation of the GATA3, which will be associated with sensorineural deafness, renal anomaly, and hypoparathyroidism. It's called the Hdr syndrome. Coming to the Kenny-Caffey syndrome type 1, so it is characterized by hypoparathyroidism, extreme short stature, mental retardation, and dysmorphism. So the mutations are in the chaperone binding protein TBC. It is required for the proper folding of alpha tubulin and the formation of alpha beta tubulin. And in the type 2, there is an autosomal dominant form of inheritance with short stature, hypoparathyroidism, and osteocraniostenosis. And the type 2 is due to the FAM111A mutation. Other associations of familial hypoparathyroidism are with mucocutaneous candidiasis, Addison's disease, autosomal recessive autoimmune polyglandular syndrome type 1, which is caused by AIR mutations, and mitochondrial myopathies, that is trifunctional protein deficiency and Kearns-Sayre syndrome. And it could also be associated with lymphedema, dysmorphism, and other abnormalities. So abnormalities in the PTH gene, point mutations in the single peptide and in an intron can lead to aberrant splicing, as well as a homozygous mutation in exon 2 of the PTH gene. Also, another homozygous mutation, the amino acid 25 PTH, is implicated. Impaired PTH secretion is seen in profound hypomagnesemia. Also, there is target organ resistance to PTH and hypomagnesemia. Could be also seen in chronic respiratory alkalosis and autosomal dominant hypocalcemia. Now let's talk about autosomal dominant hypocalcemia. There are two types, ADH1 and ADH2. So one is caused by activating mutations in CSR. They will have usually normal PTH level, so it is inappropriate. The activating antibodies are directed against the CSR receptor, and severely affected and homozygously affected individuals do not appear to have a more severe phenotype. And ADHD2 is caused by gain of function mutations in GNA11, and the clinical syndrome is variable when compared with the ADHD1, when the clinical syndrome is variable in ADHD2. It could present from hypocalcemia, subtle hypocalcemia, to hypocalcemia and seizures. And ADH is treated with vitamin D metabolites, and it increases renal calcium excretion, and also it is associated with renal if you treat with the vitamin D metabolites, it could result in a marked increase in renal calcium excretion, resulting in renal calcification and renal impairment. So to prevent this, calcium and vitamin D metabolites should be used. It should be accompanied by the use of thiazides, because thiazides will decrease the urinary calcium excretion, and also it will decrease the urinary calcium concentration. So this renal impairment can be prevented. So ADH has to be treated with vitamin D metabolites and also with thiazides. Coming to pseudo-hyperparathyroidism, this is the most important topic in this discussion, and as you can see from this slide, the slide is quite important. You can see that there is pseudo-hypoparathyroidism, and it has got three types. The type 1 has got three types, 1A, 1B, and 1C, where you can see that the response to PTH in the urinary excretion of CAMP and phosphate is decreased in all the types of 1, 2, and 3. In A, B, and C in type 1. But type 1 and type 1A and type 1C has got similar phenotypes. It causes a AHO type pattern, so it has got a similar phenotype. But in type 1B there is no such phenotype, but you have all these biochemical defects. So in all the case of pseudo-hypoparathyroidism there will be increased PTH. That's why it's called pseudo-hypoparathyroidism. But the urinary the action, the PTH action is actually blunted, or there is resistance to the PTH action. Now how 1A and 1C differs, even though it shows the same picture and same phenotype. In 1A there is G alpha S mutation or imprinting anomaly, whereas in type 1C the G alpha S function is normal. Whereas if you come to hypoparathyroidism, it has got a different mechanism. It has got the GNA S locus imprinting abnormality. GNA S1 locus imprinting abnormalities, there is 1B. If you come to pseudo-hypoparathyroidism, it looks like type 1A, but you have a normal blood picture here, and there is no other hormonal resistance. Whereas in type 1A and 1C, you can see that there is hormonal resistance to other glands like thyroid, where you could see associated Hashimoto's. Whereas in pseudo-hypoparathyroidism, only you have this abnormality, that is a phenotype abnormality in an AHO pattern, but otherwise the blood picture is normal. So it is actually due to a G alpha S mutation. And if you come to pseudo-hypoparathyroidism type 2, here you have the urinary cyclic AMP response to PTH as normal, whereas the urinary response to phosphate by the PTH is decreased, and the phenotype is normal, and the pathophysiology could be attributed to vitamin D deficiency or myotonic dystrophy. In general, the inheritance pattern of type 1A and pseudo-hypoparathyroidism is as follows. Pseudo-hypoparathyroidism happens, 1A happens when the child inherits this G alpha S mutation from a mother who has either pseudo-hypoparathyroidism or pseudo-hypoparathyroidism 1A, whereas pseudo-hypoparathyroidism results when the mutation is inherited from father with either PHP 1A or PHP PP or the pseudo-hypoparathyroidism. So when the mutation is inherited from the mother, you have the pseudo-hypoparathyroidism type 1A, and when the mutation is inherited from the father, you have pseudo-hypoparathyroidism. So you should always remember that difference. And in pseudo-hypoparathyroidism type 1A, it has got the characteristic AHO phenotype, and it has decreased G alpha S sensitivity. And this sensitivity, it has decreased G alpha S activity, and this has been found in several other tissues, including the kidney, fibroblasts, transformed lymphocytes, platelets, etc. So the features in 1A are, there is impaired cognition in about half of them, and it is due to the G alpha S deficiency rather than due to the hypocalcemia. And it could be associated with resistance to other hormones such as TSH, glucagon, and gonadotrophins. And they also exhibit a decrease in resting energy expenditure and decrease in insulin sensitivity, so they could develop diabetes in the future. Whereas in type 1B, they present with hypocalcemia, high PTH levels, and the failure of PTH infusions does not increase urinary cyclic AMP production, as I've shown you before. But the type 1B do not have any clinical features of the AHO phenotype, or it is not associated with any abnormal G alpha S levels in fibroblasts. Here the mechanism is thought to be the renal resistance to PTH, and this is the most important feature of type 1B. I will also discuss why this happens in 1A and 1B by another slide. So what are the mutations in the sporadic and familial forms? So there are two forms of 1B. There is a sporadic form and there is a familial autosomal dominant form. Sporadic form is the most frequent form of type 1B, and the mutations are unknown. Probably it could be due to the paternal uniparental disomy of 20q. There are imprinting abnormalities of the gene as locus. In some there is a gain of methylation at Nes55 and loss of methylation of XL. And in the familial autosomal dominant type, so it is chromosome 20q13.3, which contains the gene as gene, including the G alpha S, has been implicated. But the most important one is the heterozygous maternal deletions with the STX16 or the gene as, and a loss of methylation at exon A or B, which leads to decreased G alpha S expression in the proximal renal tubule. So there is a selective decreased G alpha S expression in the proximal renal tubule, which could explain why there is reduced renal responsiveness to PTH in terms of urinary cyclic AMP and urinary phosphate responses. So other deletions in the autosomal dominant form due to imprinting are, it could be even in the Nes55, or it could be in the gene as antisense exons. So when it is inherited from the mother, this causes abnormal imprinting in this locus. And Nes55 and gene as are those which shows the imprinting in type 1B, whereas STIC16 do not, these deletions do not show imprinting. So if you go back, again I'll explain this. This is called a sporadic form, and it's the most frequent form, and the mutations are mostly unknown, but it has been suggested that there could be imprinting abnormalities of the gene as. And in the familial autosomal dominant form, mostly the heterozygous maternal deletions with STIC16 or gene as is implicated. Gene as is associated with imprinting, whereas STIC16 is not associated with that. And whatever be the cause, there is decreased G alpha S expression in the proximal renal tubule. And coming to the type 1C, it presents with the same phenotype. It has got the HO phenotype and it has got the PTH resistance, but it has normal G alpha S activity. And coming to the type 2 pseudo-hyperparathyroidism, here the PTH response is normal to cyclic AMP, but there is no phosphaturic response, and also it doesn't have the classical phenotype, the HO phenotype. So the causes are not clearly known, but it is quite heterogeneous and it is different from the other, the pseudo-hypoparathyroidism type 1. It could be due to an acquired defect, or that the biochemical phenotype may be unmasked, and it is usually associated with myotonic dystrophy, and degree of PTH resistance correlates with the degree of expansion of the pathogenic CTG repeat. So type 2 is associated with myotonic dystrophy, and the severity increases with the number of CTG repeats. So hypocalcemia and primary in pseudo-hyperparathyroidism. Hypocalcemia and pseudo-hyperparathyroidism is not secondary to skeletal resistance, but it is a consequence of the renal resistance to PTH, and hence there will be low levels of 125 hydroxyvitamin D. So thus hypocalcemia occurs in the face of relatively normal bone and distal tubular response to PTH. The lack of activation of vitamin D is the main culprit here, and it results in diminished intestinal calcium absorption and osteomalacia, and this will further exacerbate the hypocalcemia. And deficiency of the calcitriol can result in hypocalcemia, which will impair the phosphaturic but not the urinary cyclic AMP responses to PTH. Now coming to Pseudo-Pseudohypoparathyroidism, it presents with the phenotype of AHO, but the biochemistry is normal. So it is found in the same kindreds, I mean the same relatives as with PHP1A, but it is never in the same sibship. You cannot find that in the same siblings who have got the same gene as mutations. So why this happens is because of the genetic imprinting. Because when they inherit the gene as mutation from their father, they exhibit pseudo-pseudohypoparathyroidism, but when they inherit it from their mother, they exhibit pseudo-hypoparathyroidism type 1A. Now this is the reason why you have these differing phenotypes. It could be all attributed to the differential expression of gene as gene. So tissues in the body normally will reactivate different copies of gene as one gene selectively. The kidneys will activate the maternal copy, while the paternal copy, if it is defective, is inactive. And since the maternal gene as is functional, renal handling of calcium and phosphate is normal, and homeostasis is therefore maintained in the pseudo-pseudohypoparathyroidism. But rest of the tissues will display the defective gene. So there will be the haploinsufficiency of gene as one product in most tissues, and this gives rise to the AHO phenotype of pseudo-hypoparathyroidism. That is because the renal function, the kidneys, the kidneys will have the normal maternal copy. The action of PTH on the kidneys will be normal, but since the other tissues have got the abnormal gene, they will have the defective gene as product, and then they will exhibit the AHO phenotype. So again, I am coming to this slide again because this is very important. You can see the significant differences again. I'll summarize. So pseudo-hypoparathyroidism, which has got two types, 1 and 2, and 1 is subdivided into 1A, 1B and 1C. If you come to 1B, the phenotype is normal, and it is due to a gene as one locus imprinting abnormality, whereas in 1A and 1C it is due to the G alpha S mutation. Sorry, it is due to the G alpha S mutation in 1A, and in 1C it's the G alpha S function is normal, but there is an imprinting abnormality, and all of these show decreased responses to PTH in terms of urinary cyclic AMP and in terms of urinary phosphate excretion. And in 1C and 1A you will have hormonal resistance to other systems as well, whereas in type 1B you don't have that hormonal resistance. And when you come to the pseudo-hypoparathyroidism, everything is normal except the phenotype, and it is due to the differential G alpha S mutation, because this differential the defective copy will be expressed in other tissues, whereas the renal tissue will express a normally maternally inherited copy. Hence response to PTH will be normal in pseudo-hypoparathyroidism. And pseudo-hypoparathyroidism 2 is a totally different entity, where there is normal response of to PTH in terms of urinary cyclic AMP, when the urinary phosphate excretion is decreased. I mean, the response to PTH in terms of urinary phosphate is blunted here. And pseudo-hypoparathyroidism does not exhibit the classical AHO phenotype, and it is related to the myotonic dystrophy. Vitamin D related disorders. So the primary cause of hypocalcemia in vitamin D deficiency is decreased absorption of calcium. So unlike that of other hypoparathyroidism, it is accompanied by hypophosphatemia as well and increased renal phosphate clearance. So this increase in phosphate clearance is a result of secondary hyperparathyroidism. So when you have vitamin D deficiency, your PTH increases and hence there will be increased phosphate loss. So there will be decreased phosphate in the blood. So you measure the serum phosphate and PTH and thus you distinguish it from other hypoparathyroidism because the vitamin D related calcium deficiency and the hypoparathyroidism could present in the same way, but you measure the serum phosphate, you measure the PTH, you find that the PTH is raised there. And in vitamin D deficiency, the level of 120, the level of calcitriol is usually low, but in moderate D deficiency, 1-alpha hydroxylase in the kidneys can be stimulated by PTH and there could be normal or even elevated calcitriol levels. So these levels, elevated levels, usually reflect the PTH action on the renal alpha hydroxylase. The causes of vitamin D deficiency could be due to lack of solar irradiation because people usually nowadays avoid long periods of intense sun exposure due to the fear of having skin cancers, and also they use high SPF sunblocks. It could be also due to decreased intake or impaired absorption as in intestinal disease, short bowel syndrome, intestinal bypass, or there could be increased requirements in obesity in the elderly or those on anticonvulsants or antituberculous medications, etc. Malabsorption plays an important role in vitamin deficiency, and because D is a fat soluble vitamin, its absorption is dependent upon the emulsification of bile acids. So any cause of malabsorption or short bowel syndrome can impair the enterohepatic biliary transport, and it could be biliary circulation could result in the vitamin D deficiency. So when there is low vitamin D, this malabsorption should be ruled out. There could be accelerated loss or inactivation of vitamin D as in anticonvulsant medications and antituberculous medications, or intestinal diseases which impair the enterohepatic circulation of the bile acids result in vitamin D deficiency due to excessive losses. As I've told you before, not only it decreases absorption, but it will increase the excretion of the vitamin D through the GI tract. Impaired 25-hydroxylation can occur in severe hepatic parenchymal disease, theoretically, but clinically it is rare because the degree of hepatic destruction that is necessary to impair 25-hydroxylation is incompatible with long-term survival. Another interesting finding is isoniazid, which decreases the 25-hydroxylation. And in some cases, there is an inherited 25-hydroxylation defect, the cause of which is really not unknown, which is not really known. Impaired 1-alpha hydroxylation can occur in renal parenchymal damage and in dialysis. So it's observed when the creatinine clearance falls to 30 to 40 mils per minute, and there could be decreased phosphate clearance in renal failure, which leads to increased FGF23, and this further lowers calcitriol and calcium levels. In any case, secondary hypoparathyroidism sets in and it increases the release of calcium and phosphate from the bone. But because of the renal insufficiency, PTH will not act, and it will not cause the phosphate to be excreted. So the serum phosphate also will rise. So calcium administration in secondary hyperparathyroidism, it will attenuate this hypocalcemic stimulus to parathyroid secretion. So calcitriol therapy is critical for the absorption of this calcium and should be administered early in the course of renal failure in the form of alpha-calcidol to avoid the secondary hyperparathyroidism, and you should monitor to avoid hypercalcemia as well as it should not be over replaced. So other causes of calcitriol deficiency or decreases should be in patients taken with ketoconazole, in ADHR and also in X-linked hypophosphatemia, tumor-induced osteomalacia, and diseases associated with high FGF23 levels. Pseudo vitamin D deficiency or rickets or PDDR, you have secondary hypocalcemia with secondary hyperparathyroidism. So there is a deficiency from dietary vitamin D deficiency. The difference from the dietary vitamin deficiency is that there could be normal or increased vitamin D and 25-hydroxy vitamin D as shown by the bloods, but the 125-hydroxy vitamin D3 levels will be less, or it will fall. So it is inherited as in an autosomal recessive fashion, and it presents in infancy with rickets, osteomalacia, and seizures. So you replace with the 1-alpha hydroxylate metabolite of vitamin D. In hereditary vitamin D resistance rickets, its resistance to the biological action of 125 hydroxy vitamin D3, and it also is inherited in an autosomal recessive way. There is hypocalcemia, hypophosphatemia, and secondary hyperparathyroidism, and it resembles vitamin D deficiency, but there is elevated 125 hydroxy vitamin D3 as opposed to the PDDR, where there is decreased 125 hydroxy vitamin D3. Another cause could be the mutations in the vitamin D receptor. So the molecular basis here is the mutation of the vitamin D resist the molecular the cause for the hereditary vitamin D resistance could be due to the mutations in the vitamin D receptor gene, and it results in impaired target organ responsiveness. Mainly the DNA binding domain of the receptor is affected, and it results in decreased affinity of the receptor to the response elements on target genes, leading to impaired regulation of these genes. And mutations in hormone binding and nuclear receptor coactivator binding domains are also seen, but it's mainly the DNA binding domain of the receptor that is mutated, and that is the cause for the hereditary vitamin D resistance. The treatment is, because of the target organ resistance to the active metabolite of vitamin D, there is no ideal treatment for the hereditary vitamin D resistance as opposed to the PDR. So pharmacological doses of vitamin D have been given, in different forms have been given, but if there is hypocalcemia and osteomalacia showing resistance, parenteral calcium infusions should be used to treat this osteomalacia. So you should always think that in pseudo vitamin D resistance you can treat with 125 hydroxy vitamin D3, whereas in HVDR, where this hereditary vitamin D deficiency, the treatment is actually quite difficult, especially when it shows resistance to the classic vitamin D preparations. You have to give calcium parenterally. Phenytoin has been implicated in target end resistance to biological effects of calcitriol, in addition to the accelerating the hepatic catabolism of the D metabolites. Also, it impairs intestinal calcium absorption. So that concludes this. I have mainly gone through the important cause of hypocalcemia. There are other causes too, but I think as for the SC, these are the most important ones. You should always learn more about pseudo-hyperparathyroidism and pseudo-pseudohypoparathyroidism, as these could be tested, especially their inheritance. Thank you.